Hello, everyone, and thank you so much for joining us. This is Georgie Carter from the Health Policy Plus project. I'm delighted to welcome you to today's webinar entitled Integrating Health Services Through Health Insurance and Financing Reforms in Nigeria. What comes next? We just have a few announcements. So this session will be recorded and we'll be posting the recording to the Health Policy Plus webinars page. We would love to hear from you and welcome your questions at any time. So please submit your questions via the chat box on the right side of your screen, and our moderator will be reading them aloud when we pause for questions. Now, these web conferencing platforms are getting a high volume of traffic these days, so we ask that you bear with us in case there are any glitches in the technology. And finally, we ask that if you are not speaking, please mute yourself to keep the line nice and quiet while others are talking. So that concludes the announcements portion, and it is my pleasure to hand it over to my colleague, Dr. Jorge Ugaz, our Senior Technical Advisor for HP+. Jorge?
Yes, thank you very much, Georgie. Good morning and good afternoon, everybody. My name is Jorge Ugaz. I am a Senior Technical Advisor on Health Economics here at Palladium, working mainly under the Health Policy Plus project. I want to start by thanking all of you for taking the time to join us on this webinar. We're aware that these are very challenging days, so we thank you for being with us today, engaging in this hopefully interesting and fruitful discussion. We will explore the future of HIV service integration into health insurance in Nigeria. And we have some works from our colleague, Mark Jambrone from PEPFAR first. Mark, can you take it from here?
Thank you so much, Jorge. Good morning and good afternoon, everyone. My name is Mark Jambrone, and I am the PEPFAR country coordinator here in Nigeria. So just by way of context, in Nigeria to date, PEPFAR has invested more than $6 billion in the national HIV response and currently provides antiretroviral treatment, including HIV/TB care services, to over 1.2 million Nigerians. This has been made possible through the strong collaboration with the US government through PEPFAR, the government of Nigeria, and other stakeholders. As we collectively strive toward achieving epidemic control, ensuring the sustainability of the gains made is becoming increasingly important. Nigeria's HIV response still faces significant funding gaps, and the program is heavily reliant on external assistance. At the community level, service continuity and client retention has been a big challenge to achieving the UNAIDS 95-95-95 targets. Challenges with retention and care can be attributed to user fees paid by clients at health facilities, which often limits access to care, especially for those who cannot afford to pay for the services. In order to achieve and sustain epidemic control, we must work to increase domestic resources for HIV from the government of Nigeria, as well as the private sector. This will require us to leverage major government-approved reforms and strategies, such as expanding health insurance access throughout the country. Through funding to USAID, PEPFAR has been supporting the Health Policy Plus, or HP Plus, project to work with government agencies and actors to develop sustainable ways to finance the country's HIV program, while closing existing funding gaps and improving HIV outcomes. One critical policy endorsed by the government of Nigeria is the integration of HIV services into state health insurance schemes. HP Plus supported NACA to develop a national blueprint that outlines the steps and mechanisms to be used by all states to commence the integration of HIV into their health insurance schemes. HP Plus is also supporting the Lagos State Health Insurance Scheme to adapt and implement this blueprint, which serves as a roadmap for the integration process. Similarly, HP Plus supported the National TB and Leprosy Control Program to develop a national blueprint for TB integration into health insurance. Currently, Lagos has made significant progress in the integration process. Up to 51 facilities have received contracts to commence HIV testing service provisions under the scheme, and 61 facilities to provide HIV services. Lagos is also being supported to increase the number of people enrolled in the scheme, which is critical to ensuring financial sustainability of HIV service delivery. Notably, a national HIV domestic resource mobilization strategy has been developed by NACA with support from HP+, to guide domestic resource mobilization efforts over the next 5 years with the potential of mobilizing an additional $6 million domestically for HIV through the public and private sectors. When implemented, this strategy can be a game changer in improving national ownership, self-reliance, and HIV epidemic control. This strategy is undergoing final review and will be published before the second quarter of 2021. So what needs to happen next? There is an urgent need for relevant stakeholders to take an all-hands approach to establish required systems that will facilitate the implementation of these key policies, including the national blueprints for integration of HIV and TB into the state health insurance, as well as the health insurance expansion efforts across the country through the state health insurance schemes. In today's webinar, we will examine the potential for health insurance coverage scale-up and integration using Lagos State as a case study. This webinar will also highlight and share lessons from the health financing reforms in Nigeria focused on using state health insurance schemes to advance progress towards universal health coverage and bridging the health financing gaps that currently exist in Nigeria today. So thank you very much, and I look forward to our discussion today. Jorge, over to you.
Thank you very much, Mark, for that kind introduction. And my apologies, I forgot to introduce our speakers at the beginning of the webinar. If we can go to that slide. So that was Mark Jambrone from PEPFAR, and after that we have our own HP+ country director, Francis Ilika from HP+. Then we have the privilege of having Dr. Serrano from the Lagos State Health Insurance Scheme. And we also have Oluwole Smile from the Lafayette Project. And then finally, we have, last but not least, Professor Onwujekwe from the College of Medicine from the University of Nigeria. And now we're going to pass the microphone to Francis Ilika from HP+. Francis, can you take it from there? And I also want to take this opportunity to remind the attendees that there is a chat box on the right side of your screen in case you want to submit any questions to the panelists. We hope to have a very fruitful discussion and Q&A at the end of the presentations. Francis, can you take it from here?
Thank you very much, Jorge, for the introduction. And thank you so much, Mark, for providing that excellent overview of the progress that has been made in Nigeria with regards to HIV/AIDS sustainable finance and initiatives. So PEPFAR has invested a lot into HIV/AIDS financing in Nigeria. The government of Nigeria is making a lot of efforts in making sure that there is improvement in HIV epidemiological control, as well as making efforts towards improving domestic financing for HIV/AIDS in Nigeria in order to reduce dependence on donors. So the government of Nigeria, realizing the problems and the huge gap in HIV financing, as well as the difficulties that could be encountered in the future as a result of these financing gaps, actually came up with a method or a mechanism for actually bridging these gaps, improving domestic resource mobilization, and improving HIV epidemiological control in Nigeria. And it is as a result of this that through PEPFAR support, the USAID project actually engaged Health Policy Plus to come up with the sustainable financing mechanisms of which we're discussing today. Now, this HIV blueprint is actually one of the documents that actually provides that overarching policy and direction for the implementation of HIV/AIDS integration into health insurance in Nigeria. Before I'll be sharing in this webinar, I'll be sharing an example of how the HP+ supported the government of Nigeria by developing this overarching policy, and how we have been supporting the government of Nigeria by supporting Lagos State to develop a roadmap for the implementation of this policy. And then I would also be sharing lessons that we have learned in doing this. Next slide, please. So it's actually important to mention that the government of Nigeria is actually implementing major health financing reforms towards universal health coverage. One of the key health financing reforms is the centralization of national health insurance through state health insurance schemes. So all the 36 states in Nigeria, including the FCT, are expected to set up state health insurance schemes through which they would expand health insurance coverage in the spirit of universal health coverage to the entire population. Now, one of the ways that has been recognized to be used in enhancing sustainable financing for HIV/AIDS is the integration of HIV/AIDS and TB into state health insurance schemes. Now, of course, we know that this is best practice because it provides that opportunity to actually ensure universal access to HIV/AIDS services, as well as the other key public diseases of public health burden through the health insurance scheme. Now, some of the benefits that have been demonstrated that could arise from this integration include that integrating HIV/AIDS into the health insurance scheme would actually help to address the funding gap for the national response towards epidemiological control of HIV/AIDS. In addition, it will also provide financial protection for people living with HIV/AIDS, which aligns with the spirit of universal health coverage. It will improve access and HIV outcomes, and it will also reduce donor dependence in the long run. So HP Plus provided support to the government of Nigeria in collaboration with the National Agency for the Control of AIDS, with the National Health Insurance Scheme and state health insurance schemes to develop a blueprint that would actually outline how this integration would be conducted in practice. So this blueprint document contains and defines a minimum package of HIV services that are seen to be appropriate for the context of the country and would be feasible for integration of HIV/AIDS into the health insurance scheme. It actually lists the providers that are needed to provide these services, and it also provides guidance to the state health insurance schemes on how to purchase this package of services, including the payment models that they would need, the contracting mechanisms, as well as the purchasing mechanisms that will be required. And then, of course, it also discusses additional implementation considerations, including roles and responsibilities of different stakeholders, monitoring and regulation mechanisms. Next slide, please. So the blueprint development process was actually a very inclusive process. So it involved all the stakeholders that were needed or that had a role to play in implementation of the HIV response in Nigeria, including national agencies, the NACA, the National Health Insurance Scheme, the State Health Insurance Scheme, providers, both public and private, CSOs, people living with HIV/AIDS, and everybody that had a role to play in the implementation of this integration blueprint. So this blueprint provides a guideline, a national guideline that will be used by the 36 states to integrate a minimum package of services into their health insurance scheme. And the technical design was actually brought about by a thorough review of existing literature, existing practices in other countries that have actually attempted to do this integration, feasibility assessments through actuarial analysis, defining of benefit packages that are seen to be feasible within the context of Nigeria, defining standards of care management protocols, and considerations both for the short, medium, and long term for this integration. And maximum stakeholder input was actually acquired through roundtable workshops, consultations, and discussions with key agencies, institutions, and individuals. So the process so far started in October 2019, and there was a roundtable with key stakeholders. And after that, by February 2020, there was a draft national blueprint. And this blueprint was endorsed by the National Health Insurance Scheme in June 2020. By December 2020, following further consultations and improvements on the document, during the World AIDS Day celebration on the 1st of December 2020, the government of Nigeria, represented by the Minister, Honorable Minister of Health, and the Secretary to the Government of the Federation, actually endorsed this document as a national policy that would drive health insurance implementation as well as integration of HIV/AIDS into health insurance. Next, please. So what does this blueprint contain? So this blueprint actually provides an overview that defines the benefit package. According to the blueprint, it is recommended for the Nigerian context to actually include integrated testing and counseling of HIV/AIDS services into health insurance, antiretroviral initiation, treatment monitoring, and follow-up at the minimum. So this is the minimum package of service that should be included in the health insurance scheme in order to achieve the goals and have this integration process effective. Now, it also outlines providers that should be included, and this should be public and private. Of course, we know why, in order to expand the reach so that people in remote communities will be able to have access to HIV/AIDS services. And then, of course, primary healthcare centers are very central, because this will also expand the reach of the people that are able to receive these services, as well as help in building the health system of the country by building up services, quality of care at these primary healthcare facilities. Now, it also outlines the payment mechanism, and after consultations and evidence generation and different consultations with stakeholders, it was actually recommended that the payment mechanism for payments of HIV/AIDS services in the health insurance scheme will be capitation, and capitation for testing, for services like testing, and then outcome-based top-up mechanisms for services like ART, as well as treatment monitoring and follow-up. This is to incentivize adherence and actually the results that are needed in getting people tested, in making sure they are linked to care, and also ensuring that when they are linked to care, they adhere to care, and that they're able to have viral load suppression. So the blueprint also outlines the different steps that are needed to contract providers, including from the accreditation of these providers, recruiting them, as well as finalizing the contracts that they would need to be able to provide care through the health insurance scheme. It also outlines how benefit package should be expanded over time. So it is recommended that depending on the financial feasibility of the scheme, we should start with a minimum package, and then support services will be added over time. And then at the end of the day, commodities, which are usually, the most difficult aspect to be added to health insurance coverage because of cost considerations. Now, the blueprint also outlines governance, reporting, and monitoring and evaluation mechanisms, and also provides a roadmap that states and even other countries can actually take to the implementation of these blueprints. Next slide, please. So what progress have we made with regards to the implementation of this blueprint? Like Mark said, the HP Plus was not only involved in the development of this blueprint, but we also had to pilot this in Lagos State, starting with Lagos State and initially in Kano State, in order to demonstrate that proof of concept that this could actually work, and also to learn lessons from the implementation that would actually feed into scale up to other states, as well as in other countries that are actually considering integration of vertical programs into their health insurance scheme. Next slide, please. So after the development of the blueprint, HP Plus supported Lagos State, which actually is very well positioned to be able to drive this process. Lagos State is known as the center of excellence in Nigeria, and their health insurance scheme is actually at a very advanced stage where they've actually started enrolling people and providing services through the health insurance scheme. So HP Plus supported Lagos State to develop a roadmap that actually outlined what things to be included, at what times these things will happen, the roles of different stakeholders, as well as the different mechanisms that would be employed. So this roadmap actually highlights the planning that needed to happen, including the evidence generation, the actuarial analysis, feasibility studies, and things that would need to provide information that would inform what will be in the benefit package and the way that the scheme will be implemented. It also provides mechanisms for contracting providers, enrollment of beneficiaries into the scheme, the launch of HIV service provision into the scheme, which is expected to happen by the second quarter of this year, as well as the ongoing monitoring and reporting that is required to be able to assess the effectiveness of the purpose of this integration in the first instance. Next slide, please. So we've made a lot of progress in Lagos State, and I would like to highlight this in this slide. So, so far, significant progress has been made. We have been able to support the Lagos State government and the Lagos State Health Scheme to reach maximum stakeholder consensus among the different agencies, people, and individuals and institutions that are responsible for HIV control efforts in the state. We've been able to support Lagos State to develop provider mechanisms for payment of HIV services through the health insurance scheme. Lagos State has actually adopted to pay for HIV services through capitation for testing, and then for treatment and treatment monitoring, they are opting for fee for service. And this aligns with the current payment mechanism that is being used by the health insurance scheme. As at today, close to 120 HIV facilities service providers have been empaneled onto the scheme to provide HIV services, and about 61 TB service providers have been empaneled as well. We've also supported establishment of logistics and supply chain linkages for HIV services by linking the state health insurance scheme to the bulk purchase mechanism that is currently in use by PEPFAR and the Global Fund, so that these facilities can actually purchase HIV commodities when they need it in order not to cause any disruptions in care. Of course, we've also supported them to put in place monitoring and evaluation mechanisms and indicators to be used to track service provision under the scheme. Referral networks have been established to ensure progression along the cascade of care and prevent any form of disruptions or people falling out of the treatment cascade. And then, because it is very important to ensure financial feasibility of the scheme, we've also provided support to the Lagos State Health Scheme to expand coverage, because when more people are enrolled into the scheme, this improves the financial viability of the scheme, and that makes it possible for the scheme to be able to integrate HIV/AIDS services. Next slide, please. So this schema actually outlines the processes that HP Plus employed towards this integration in Lagos State. Of course, before we came, not a lot has happened with regards to integration. And we started by supporting the development of this national blueprint, which serves as a policy guide to all the 36 states for their integration process. And then we started a pilot in Lagos, where we've helped them to develop the benefit package, to include HIV services and integrate it into the benefit package, and panel facilities that will provide these services, as well as support the expansion of people who are enrolled into the scheme in order to improve the financial feasibility of this integration process. In the foreseeable future, we actually see great impact of this. We anticipate that by the end of the first quarter of this year, about over 3,000 people living with HIV/AIDS will begin to access care through the health insurance scheme. And by the end of the year, this could actually be much more than that, or over 17,000 people. Next slide, please. I would also like to mention that we provided the same support to TB by supporting a national blueprint for TB, which has been developed and endorsed by the government, and also developing a roadmap for integration of TB services into health insurance scheme in Lagos State as well. And this would also lead to similar outcomes for TB. Now, what are some of the lessons that we've learned, and what recommendations do we have for other states and settings? Next, please. So one of the recommendations that we have is that evidence generation is very important. So to be able to embark on this journey, you need country or state-specific evidence on what is needed, what is available, what service providers are there to provide the services, what is the financial feasibility or financial capacity of the health insurance scheme. This will determine what services they can take on, what will happen in the immediate term, what will happen in the medium term, and what will need to happen in the long term. And this will also advise on what steps to be put in place to actually make the scheme more viable to be able to do this integration. Government involvement is very important. And I must mention that capacity building is going to be very key. So for instance, now that we have the national blueprints and we've developed the roadmap for Lagos, and Lagos is providing this proof of concept about how successful this can be, other states in the remaining 35 states and the FCT will need similar support to be able to develop their own processes, develop their roadmap, and implement them effectively. Of course, we also advise a phased integration. So an introductory stage that would actually start with the minimum package of services that we recommended in the blueprints, and then this will be scaled up over time, especially in a setting like Nigeria, where many states are still at the beginning stage, and so they don't have the numbers yet to have that large financial capacity to provide health services or a more comprehensive package of healthcare services. So we advise that you start off with this minimum package and then expand over time as the financial capacity of the scheme increases. Next, please. So this schema actually outlines the different steps that needs to be taken, the early stage, the advocacy, consensus building that needs to happen, the assessments, feasibility assessments that will determine what should be added or not, the launch of the scheme, which will include planning, where will these services be provided, what providers will be doing this, the monitoring that needs to happen to ensure that this is actually happening in practice, and then the evaluation to ensure that the purpose of this integration is actually working out in practice. Next, please. So finally, I think based on the experience of HP Plus supporting this integration process in Lagos State, as well as providing support to Nigeria, we've actually seen that this is possible, this is feasible, both financially, technically, and operationally, to integrate HIV services into health insurance in keeping with best practice. And this will actually be a more efficient way to implement the health insurance schemes and health reforms, rather than actually having this as vertical services. And then health actors actually encouraged to use evidence-based engagement and advocacy to get the different stakeholders together. For instance, stakeholders need to be convinced about the benefits. So mutual benefits will need to be identified. The different stakeholders that play a role will need to understand the roles that they play. And perhaps one of the important things is for stakeholders to understand that integration of HIV, AIDS, and TB into the health insurance does not mean that the agencies that are responsible for the services will close down. No, what it means is that everybody works in a more integrated and coordinated and harmonized manner towards providing these services. And of course, we advise that there needs to be a clear integration strategy, which this national blueprint provides for Nigeria at the moment. Maximum stakeholder involvement and consensus is necessary. Mutual benefits needs to be identified and risk need to be managed. So as countries make their progress towards universal health coverage and universal access to care, it is very important to actually integrate these services that are of high disease burden and actually make sure that processes and mechanisms are put in place to make sure that they are successful, and this will eventually help to enhance equity in access to healthcare and health outcomes. So at this point, I would like to introduce Dr. Serrano, who is the Director of Operations from the Lagos State Health Scheme, to actually give us firsthand experience of how this integration process has been for Lagos State, as well as share with us the current efforts that Lagos State is making towards expansion of health insurance coverage. Dr. Serrano, please.
Yes, good afternoon. Thank you very much, Frances. for words. So Dr. Serrano, I was speaking with respect to the legacy health scheme and how far we've gone with respect to the HIV integration and the legacy health scheme as a whole. So please, next slide, please. Okay, so the legacy health scheme, for its creation, we had to create some form of regulatory framework, so it should not be an executive order. So the legacy health scheme was signed into law in May 2015, and in signing the legacy health scheme into law, 3 entities were created. You had LASHMA, the agency responsible for the scheme. You had the scheme itself, and you had what we call the LASHEF. Now, the original plan and the ongoing plan is that every facility, whether public or private, in a public-private partnership situation, will be able to render services under the Lagos State Health Scheme. And the choice of facility is purely based on that choice of the enrollee. Now, for the benefit package, in the design of benefit package, the core thrust of the benefit package in the initial design was, one, let's have something that is common to everybody, that most people suffer from. Let's have what is affordable and what most people need. So the focus was primary care, some secondary care services, maternal care, newborn care, and a slight bias for maternal and child health. So that's where the main focus of Lagos State Health Scheme is. Considering economics of Lagos, pricing was a major factor because in health insurance, the more benefits you add, the higher the cost to be. And if you have the economic situation of Nigeria, certain things were excluded for the meantime and say, okay, put that in the back burner, then with time we'll put it in the front burner. So for the Lagos Health Scheme, the premiums were designed at $40,000 or $100 for a family, and the definition of the family is husband, wife, 4 children less than 18, and where the family has additional children, more than 4 children less than 18, every additional child is an additional cost of $16. Now, for those that are currently running in Lagos and doing their businesses in Lagos as live alone or work alone or live alone, so their premium, and adults, their premium is $23 per annum for these benefits. So whether on family plan or single plan, you enjoy exactly the same benefits. Now, in the design of the scheme and signing into law, with the poverty levels in Nigeria, provision is actually made for the poorest of the poor within the Lagos State Health Scheme, such that a certain percentage of all government revenue be assigned towards paying for premium for the poorest of the poor people within the community, such that they get 100% subsidies. So those living in the urban slums and rural slums in Lagos have access to health insurance scheme and do not have to worry with respect to the cost of the scheme. And for those that are government employees of the state government, they get partial subsidies. So all public employees get partial subsidies. Next slide, please. So now, in terms of our integration plan and what we plan to do, so we have a clear-cut strategy. Now, in Nigeria, not all facilities offer HIV services. So we had to find a way of merging those facilities together. So you can see from the diagram, you have 2 spaces. You have the Lagos State Health Team space, which is in orange, and the HIV space, which is in red. So you have some facilities that offer the LSHS services, but don't offer HIV services. You have those that offer HIV services, but are not part of the LSHS. I have those that actually offer both. That is the blue facility. So what are the strategies that we're looking at? So currently, because the HIV is not currently a core benefit under the LSHS, HIV management, so we are taking advantage of the currently existing referral network. So you can see number 1, which is same thing on the map, we have improved referral processes from LSHS facilities to HIV supported facilities. So once you are on the LSHS, we ensure that once the person is tested and tested positive, the person is referred to the facility. Now, in terms of other benefits which I left out, was that HIV testing is covered as part of medical care and for all pregnant women that are there for antenatal. So number 2, referral, where a situation whereby the nearest facility is not an LSHS facility, we encourage facilities to refer to the nearest HIV facility. So all our facilities within the LSHS have a referral template such that they're able to refer people from their own facility to the nearest HIV facility. Now, the 3rd step is improving capacity, which is a major thing. As I said earlier, not all facilities offer HIV services. So the plan in support with HP+, which has been ongoing, is to get more facilities to provide HIV services, such that it's not specific facilities in Nigeria or Lagos that provide HIV services. Then the 4th step is having to get those facilities that are currently supported by organizations and currently provide HIV services to be part of the Lagos State Health Scheme. So the plan is that to have much more hospitals that will fall into the blue section of the scheme. So that's the first stage, improve capacity of facilities. Next thing is also encourage more people, more facilities to join the scheme. Now, the final plan is actually full integration such that we treat malaria once capacity has been built. We treat HIV services as you would treat every normal condition like a common cold or upper respiratory infection. So that's a long-term plan, and we're currently in that process. Now, some of the factors that affect it include supply chain management, which HP Plus has helped us in linking up with PEPFAR, the bulk purchasers. So those are some of the things, because in terms of costing and all that, some of these things affect the availability of HIV services. The next slide, please. So our expansion strategies. So we are based on the slide. Unfortunately, right now we have about 274,000 people that are currently part of the Lagos State Health Scheme, whereas Lagos has a population of 20 million plus people that are currently part of that are residents in Lagos. Now, in Nigeria, the culture of health insurance is actually not there. So people assume that asking somebody to buy health insurance is like asking them not to have faith in their various deities. So some of those things have to be considered. So what we now did as an agency to push down and drive down health insurance is, one, ensure we have our in-house marketing structure such that we have staff that work within the agency that go out into the community and engage people in educating them and telling them the benefits of the health insurance scheme. These also go house to house, door to door, corporate entity to corporate entity. Then we have partnerships with public-private organizations. So you have health insurance organizations that are currently serving and operating within the Lagos State space. And we have our care providers. Now, care providers currently provide care for everybody in Lagos State. So we've encouraged them to be part of Lagos State Health Scheme to register people. So there are two incentives for them. One, they get enrollees and they also get revenue from registering people who, of course, would naturally want to choose their hospital. So the more people they register into the scheme, the more revenue they get, and of course, expanding the scope of the scheme. And we've also partnered with banks and microfinance organizations to ensure that those that are unable to pay are able to have some form of succor in terms of instrumental payments for the scheme. So we have informal sector unions. You can see from the picture, that's a market union where we engage with trade unions, artisans, to see how they can come up as a collective to be part of Lagos State Health Scheme. So also we have publicity campaigns, radio campaigns, billboards, social media presence to drive the scheme downwards. So we've actually also launched what we call the ILERA campaign. That's the Yoruba word for the health of Lagos State, such that people in rural areas can communicate and be part of the Lagos State Health Scheme and not just think it's an elitist thing. They also have the regulation with respect to the health insurance scheme. So we currently have health insurance players in Lagos State. However, it's not fully and properly regulated. So the agency itself is ensuring that one, regulate the process and ensuring quality and standards within the health insurance space, and ensure that nobody is cheated and both the insurer and the providers meet the set standards. Next slide, please. So you can see from pictures, you can see our various activities going out into the communities, doing the outreach to meet people. Now, our plan this year is to reach 3.5 million people at least. So that's our plan. So we have the informal sector, who are a larger portion of Lagos State. We have a large majority of Lagos State being informal sector. We have corporate entities. So we are looking at about at least 400,000 people that work for corporate entities and SMEs to be part of Lagos State Health Scheme. I have civil servants who are also by default, since they are state employees, and get subsidies. So we believe that with 3.5 million enrollees, that will provide some form of protection for a large number of people and puts us in a better position to cover more people. And of course, these 3.5 million enrollees, we know that some of them will definitely have HIV or TB. And we know that by doing that and integrating, the scheme will work very well. So thank you very much. And I'll be handing you over to Dr. Smile, who will be speaking on bridging the health financing gap in Nigeria. Thank you very much.
Thank you very much, Dr. Serrano. And now, again, it's time to move on to Dr. Oluwole Ismail. He's a health financing expert from the LAFIA project, and he will be talking about financing pathways for Nigeria on their way toward universal health coverage. Dr. Ismail, we're ready for you.
Yeah, thank you very much, George. Hi, everyone. I'll be speaking on the bridging the financing gap towards achieving UAC in Nigeria. Next slide. As we all know that UAC is a goal. Next slide. UAC is a goal to be achieved, and there are set targets through the Sustainable Development Goal target for UAC in Nigeria by 2030. Next slide, please. I'm using this outline for this presentation. Okay, great. As I said earlier, that there are SDG targets for UAC in Nigeria, by 2030, and those targets are basically what you can see on the screen. In terms of the MMR, that is maternal mortality ratio, 70 to be achieved, 70 per 100,000 live births to be achieved by 2030. On the 5 mortality ratio, 25 per 1,000 live births. And the key question here is this: given the trend for the past last decade, from 2008 to 2018, and looking at the future of 2030, are we really on the track? We are really sure that we can really attain this target that has been set? So that is the key question, the key issue to be addressed. And if you look at the trend from the last 10 years, you will discover that the maternal mortality ratio only barely changed by 6%. And if you have to achieve the target for UAC by 2030 in Nigeria, that means that line needs to bend by almost 81%. And that is the key question, and that's the key issue there. You look at the country plan, National Strategic Development Plan 2 set a target of 288 per 100,000 live births for maternal mortality ratio, and that is just by next year. So in the DHS 2018, we were at 512. So how feasible is this target set in the country plan, and also that of the SD target, given the last trend in the last decade, to be able to achieve this target that has been set? And if you want to look at the financing side, you discover that out-of-pocket expenditure has been moving around the very high, and has just remained flat as well at around over 77% of the current expenditure. So if we are to achieve this UAC target, it means this line have to bend, and that the key critical issue. You have to bend towards about 30 to 40% of current expenditure, which is the UAC target. And also look at the public expenditure on health per capita. Currently now from 2010 over about a decade, we see moving from 10 to 12, and the target is about $86 per capita. And you know that for this public expenditure to really move, the health insurance scheme have to move, the social health insurance scheme have to move. So you look at the line on the that green line on the zero line, that is social health insurance. That all the figures are from national health account. Social health insurance currently at a share of the current health expenditure, just moving from 1.1 to 2.7, whereas this needs to move up rapidly to about 60% before we can be talking about achieving UAC in Nigeria. So you could see clearly from this slide that the poor health statistics we have in the country is a very good reflection of the low public investment that we have in Nigeria. So, and the critical challenge here is that for us to be able to move towards achieving UAC, the public expenditure has to rise, and for it to rise, the social insurance scheme in Nigeria have to be well expanded. And we really appreciate the new decentralization of the NHIS operation in the country that have really led to the emergence of state insurance scheme being driver's seat. So how do we really leverage on these state insurance schemes to be able to change this landscape, to be able to bend the line towards the UAC target and the critical issue that we have to address in the country? Now, looking at the macroeconomic environment, as well as the fiscal space, the fiscal landscape, there are some hope. You will see the growth in the economy. That's the GDP moving from 0.9 to 2.3%. Although in 2020, COVID-19 came to disrupt the whole landscape. But the good news is that we are able to get the news from National Bureau of Statistics that this Nigeria has exited from recession. And the implication of this for the health sector is that there are great potentials for health sector to be able to mobilize some resources from the economy, as it will be seen some of my recommendations later on in this presentation. Looking at the fiscal space, you will see a gradual shift from dependence on oil revenue towards the non-oil revenue. In 2010, just about a quarter, about a quarter of the inflow to the government fiscal wallet comes from non-oil. However, by 2018, it's moving gradually towards the half of the fiscal space and the inflow accrued to the government. So this informs predictability. This guarantees some level of sustainability of government initiatives, including the health sector. And if you also look at the burden that needs to be addressed in the country when it comes to the insurance coverage, looking at our demographic context, the population pyramid, and also the labor market structure, you will agree with me that there are quite a lot resources that is needed to actually bridge the gap. Looking at the population pyramid, we have about 45% dependency. Looking at the labor market, we have another 25%, another quarter of the population that are economically dependent. The time will not permit me to talk about the implication of unemployment and underemployment on the oil financing landscape. So in aggregate, about 3/4 of the population are economically dependent. So if you have to really expand insurance coverage after we are able to successfully capture the low-hanging fruit of the formal sector, so what next? How do we start thinking how to really increase the resources? And we do not have to wait, just like the story of NHI that has been sticky for the past decade, all because there were no actual plan to see how to capture the vulnerable that have to become the primary responsibility of the government. Next slide, please. Okay, so last year at the onset, we are just about to conclude the first year of the last year program. At the onset, we were able to look into all this and develop a working document which aligns with national health financing strategy to be able to see how can this current health financing landscape, because from the context I showed earlier, you will discover that for us to have a bend in the trend of maternal mortality ratio, under-5 mortality ratio, and every other key health outcome indicators, definitely the OOP have to bend towards the target, the public expenditure to move up. And how do we achieve this? Is by developing some strategies which flows with the current emergence of state insurance scheme through transiting from private financing, predominantly out of pocket, over 77%, to public financing, which is not just public financing like discretionary, but which is predictable, sustainable, and responsive. And that's one of the core strategies that LAFIA will be looking at in supporting government of Nigeria as we move to change the current trend of the both health and financing indicators. They are also not only predictable now, it also must be targeted towards the poor, it must be poor in nature. The current major investment of the government right now is targeted towards the tertiary and secondary facilities, meaning that which is over 90% from the national health account, and you know that these are well situated in the urban centers. How do we really target, reach to the people that most need, which is estimated to be over 60% of the population in rural communities? So that is one of the critical issues that, core strategy that, that are contained in that working document of LAFIA program in supporting government of Nigeria to be able to achieve a very responsive, financing arrangement in the country. And also emphasis on primary healthcare services. From national health account, we have seen that only 16% of primary healthcare service expenditure happen at the primary healthcare facility level. Over 80% happen at non-PHC. So how do we ensure that there's a system in place that can ensure the convergence of these other expenditures over 2 trillion naira, that happens at non-PHC to what convert towards the PHC facility level by conditioning the point of entry using the vehicle of social insurance scheme as a point of entry to the health system. Next slide. Okay, so even within this landscape of the social health insurance in the country, there are basic financing pathways that the government of Nigeria has to explore. And in our support, LAFIA program support to National Health Insurance Scheme, Kano State Health Insurance Scheme, State Contribution Scheme, as it's been called, and other states, these are being we are really engaged the NHIS and also the Kano State scheme on this, which we also hope to engage other states so that we can really understand the goal and the target that we have in mind as we drive the vehicle of additionals in Nigeria, not just focusing on the low-hanging fruit, but again, those particular groups that require, some help, that require their burden to be absorbed by public investment. So we have these 4 parts. We all know that the part 3, part 4, from our engagement with NHIS and Kano State scheme, we all agree that part 3, part 4 are not really actually feasible to follow, given the lack of equity standards and also very high fiscal burden that is not even really feasible. But the debate has been between part 1 and part 2, which one is we are really ready to follow. We all agree that part 2 is the desired, pathway to follow, where we most for equity, and also they definitely no argument about that. The poor and vulnerable have to receive full subsidy, but the informal sector can have some set of, some kind of partial subsidies. But this requires, high-level data management platform, that can really help to drive this. But currently, the system is still weak, though the recent NIN registration may give hope in the near future. But most of the government now, both at federal and state level, are at least doing the part 1 with the hope of transiting to part 2 in the near future. Next slide. Okay, so LAFIA program, basically at the outset, supporting Kano, Kaduna, Borno, Jigawa, and Yobe states with other states, Lagos, Zamfara on COVID-19. But for the sake of time, let me just focus on some of the support we have, extended to Kano State government towards ensuring predictable financing of the health sector. And one of the recent things that just happened is the 1% of the CRF be earmarked to state contributory management agency. And also in the same health sector, there is what we call Kano State Health Trust Fund, okay, which is also attract 5% of state IGR as well as the 1% of the LGS statutory revenue. So these are predictable, backed by law. These are predictable, and we hope to see more of these in other states as we begin to drive the vehicle of social insurance in Nigeria. Next slide. Okay. As part of our support to national insurance scheme, given the presidential mandate, to NHIS to develop 10-year strategic development plan, being the first time NHIS will develop a strategic plan since its existence. LAFIA program was able to support NHIS, to review the plan and then cost the plan for the whole 10 years. After that, we also did some financial sustainability analysis, as well as the investment case that shows the impact on the financial landscape, how the whole financial landscape will change as a result of the public investment into social insurance scheme in Nigeria, and also the impact on the economic growth. And one of the key findings, NHIS will still disseminate the whole plan with all the costs and the implications of that. But from the national financing policy that also have highlighted some potential sources, and also in alignment with what NHIS has also, data program have been able to support NHIS with, we discovered that looking at the various opportunities, potential resources that are available, both from the fiscal space of the government, from the fiscal space, as well as from the economy at large. We have 2 scenarios. The first scenarios are the one listed there. Time will not permit me to really run everything down. But the key method here is that if we're able to achieve these ambitious scenarios, we will be able to cover about 50% of the vulnerable group in Nigeria. And getting the 50% then becomes what? An issue, looking at other social investment opportunities. And the last slide, in terms of the way forward. So looking at the way forward, we must ensure strong advocacy to government to really earmark greater than 1% of the equity funds, canvas more earmark from the economy, place emphasis on PAC, and support the implementation of BACPF. Thank you very much. Over.
Thank you very much, Dr. Smile, for that thorough presentation of the LAFIA project and the challenges ahead. Now, last but not least, our colleague and Professor Obinna Onwujekwe from the College of Medicine, the University of Nigeria, will share some thoughts with us about the future of health in Nigeria. Professor Obinna, the mic is all yours.
All right, thank you very much. So, well, I mean, as we've had a lot today, as we look to the future of the Nigerian health system, I mean, what's important is that, you know, we need a new thinking. You know, we can't be rigid in our thinking. So, I mean, what is happening in Lagos with HIV being integrated into health insurance, it's part of the new thinking. So that's basically how we can achieve UAC, because it's obvious that if we stick to what we are doing, what we've been doing for the past 50 or 60 years, nothing will ever work. Next slide, please. So as I think about my conceptual framework about, you know, about universal health coverage in Nigeria, I think some have been mentioned. Oluwole Smile just mentioned about the NHS, National Health Insurance Scheme Strategic Plan. So, but I think we need enabling policies and all that. I mean, they're quite important. But I think it's also important to improve on efficiency of use of existing funds. I think integration of HIV control into health insurance may actually help us to improve the efficiency of use of available funds for HIV. But we also need more money for health. You know, once we take care of the governance issues about pumping money and money leaking, we definitely need more money. But we need to be innovative. I mean, we heard a lot about LAFIA and all that. We need to be innovative. But I think what we're still missing, you know, in the future health system of Nigeria is that we need to mainstream health in all sectors. Health is not that mainstreamed like gender is mainstreamed everywhere. Health has to be in all policies if we are to mobilize adequate resources, especially bearing in mind the issue of social determinants of health. So we can't achieve universal health coverage if we don't mainstream health in all sectors and mobilize resources from all sectors: education, transportation, defense, and all that. And then, of course, an overarching theme there is improve equity. I mean, it was one of the criteria from Smile's presentation. We must make sure that nobody is left behind, no matter your gender, economic status, and all that. I know, and with that, we can think we will be on the road to achieve our SDG health targets, you know, which includes universal health coverage. Next, please. So, but I think strengthening health systems to achieve UHC is, I mean, we should talk. Next slide, please. We'll talk about, you know, how do we build a health system backbone? I think nothing is really new. You know, we keep just that, you know, we have policies and plans that people are not aware of, and that are not being implemented. I think we have a new national health policy. I don't know how many people have read it and perused the content and digested it. I mean, let's implement that policy and the National Health Act, you know, as they are. We haven't implemented them. If you can implement them with a reconstruction of the Nigerian health system, and recognizing that states, the states are almost semi-autonomous, you know, recognizing the federal status of Nigeria. So when I talk about government, you know, we should also imply state government. I mean, we've seen that in the COVID control. Each state is basically doing its own thing and flexing its muscle. So, you know, a national thing, well, can provide a framework, but each state has to come in and develop its context-relevant state health policies. We see that the LAFIA project is doing that in different states. They're all doing different things. And then, you know, I keep mentioning that to build a future health system, we need to have health in all policies. It's not possible to make any progress in Nigeria the way it is now until we mainstream health in all targets. And then this brings the idea of a health in all policies, you know, which targets the key social determinants of health through integrated policy response across relevant policy areas with the ultimate goal of supporting health equity. I mean, we've seen that because health has not been mainstreamed in all sectors, you know, we use the response to COVID, you know, whether it's risk managed communication and all that. You see, there's a lot of non-alignment of activities by different sectors. Next, please. So the future of Nigerian health in Nigeria, that's like I said, the innovative imperative. So we've seen one innovation in Lagos State, HIV integrated into health insurance. I mean, some aspect of HIV, which I'm sure is going to save a lot of money that is put into the vertical HIV control programs. You know, if it's just integrated, all the admin fees alone, I'm sure that will be enough to take care of whatever will be the premium that will be needed to pay for HIV patients. You know, we are going to eliminate a lot of waste. So we need to be innovative, you know, and then I think part of this innovation is if we are to achieve UHC, integrating HIV into health insurance, that all the states have to come out with their plans because each state is unique. So we need to have each state, we've been saying this since 2014, each state must have its own plan for UHC, including the an FCT, and then the federal. What are their plans for achieving UHC, and then implement such plans. But I think I'll finish with this slide. I mean, we can achieve good health at low cost. It's not just about pumping money. You pump money, we've seen a lot of millions pumped into Nigeria and they all disappeared. Nothing has happened. I mean, we saw the slide that was shown by Oluwole Smile. It's you know, we have a very the projections are not likely to work, not because of lack of money, but we can achieve many things with good health at low cost, which involves so many things, you know. But I think one important thing is strong political commitment to good health, a high degree of community involvement, ensure equity of access and use, and sustain investment in health systems, you know, especially primary health care. And I think for me, it's also important to sustain investment in health system governance, ensuring accountability and reducing corruption, which leads to lots of waste. Thank you very much.
All right.
Thank you.
Thank you very much, Professor Urbina, for that thought-provoking and I'm sure quite polemic presentation. I'm sure that some of the questions are going to be coming our way over the next few minutes. The first question that I have, it's somewhat related to the HIV blueprint. If you can go back to slide 9, please. So, and this is important just to sort of like present explain a little bit the background. The massive milestone that was achieved last December 1st of 2020, that was on the world's 8th day, when Nigeria officially launched the country's national blueprint for integration of HIV into the state health insurance schemes. That was presented by Dr. Francis Ilika. And this blueprint was developed by NACA, by NHIS, and other HIV stakeholders with support from HP+. The blueprint was made available on NACA's website just a couple of weeks ago, and we actually invite all of you to review it, as each state, as we know, will be required to adapt the blueprint based on their unique context. So with that, with that in background, I have a couple of questions for Dr. Francis Ilika. The first one is, what have been the challenges with the implementation of these blueprints, of this HIV blueprint, and how were they overcome? And 2, the biggest cause of vertical program service delivery are the commodities, especially with HIV now being handled with differentiated care, reducing patient visits. And yet we see that insurance programs are sometimes reticent to pay for commodities, whether we're talking about test kits or whether we're talking about antiretrovirals. And how do we address this, both strategically and also operationally? Francis?
Thank you very much, Jorge, for the question. So the first question, I'll start from the second question, talking about the commodities. So that is actually a practice that we see very commonly, where because many of the states are just commencing their health insurance schemes, they don't have the financial capacity at the moment to actually take on high costs of activities. Now, one thing is very sure, for the state to be able to have that financial capacity to take on these commodities, they need to build the financial capital of the state. And we've been talking about it. For a country in Nigeria, it's a big challenge because we have a large informal sector. And Lagos State and so many other states, another state is Kano State, that have made efforts to cover the formal sector, are still not able to cover more than 2% of the population, because the bulk of the population is in the informal sector. So that progress towards reaching that missing middle, reaching that difficult to cover informal sector, in order to generate adequate resources that would go into the scheme, that would enable the scheme to be able to cover more services, including commodities, is quite a challenge in Nigeria. You know, in some other countries, they were able to reach about 85% of the population coverage before they were able to take on these additional services. Now, some of the things that Lagos State has been trying to do to address this is that there is an actuarial analysis that is actually going on. An earlier one done actually estimated that it will require additional 200 Naira, which is about 50 cents per person as additional premium to be able to cover HIV services, including drugs and commodities. Now, this is based on the condition that everybody, the whole over 25 million population is enrolled into the health insurance scheme. So what this makes us to realize is that population coverage is everything. And Smile also spoke about it. Professor Onwujekwe also spoke about it. So I think perhaps one of the first steps is actually discovering how do we expand population coverage so that we can expand the financial viability and capacity of these schemes so that they can take on additional services. In some other settings, one of the things that they've actually explored is having government mechanisms for procurement of these commodities continuing to be in place as buffer or to complement purchase of these commodities through the scheme. So some countries have actually not been able to move to have the health insurance schemes cover these commodities. They are still procuring it from government budget processes and then using it to subsidize the schemes while the schemes focus on labor charges, monitoring and other clinical care settings. But of course, we all know that this can only be a short or medium-term strategy. The long-term strategy will be for the scheme to absorb the cost of these commodities. And one way to get this to happen is by expanding population coverage and all the measures that need to be in place to be able to have that maximum population coverage that will give the scheme the financial viability that it needs. Now, reflecting a little bit on the challenges and how some of these challenges have been encountered, I think I often like to group the challenges into financial feasibility challenges. I've mentioned some, some of these states are still at the nascent stage of starting health insurance scheme. So because they are still at this initial stage, they still don't have the finances that they need. So that financial viability is actually very important. And many states are actually going ahead. USAID supported many states to conduct actuarial analysis that will help them to decide what exactly they should be included at the moment. So Lagos State at the moment is covering testing services because that is what they've deemed to be financially feasible for them. So that same kind of mechanism will need to be applied elsewhere to say, what can we financially cover at the moment? Now, in addition to financial challenges, of course, technical feasibility challenges. So what's providers are providing services, where are they, how do we integrate this, what will be the roles of different stakeholders, as well as operational feasibility issues. So of course, there are different stakeholders at stake. So perhaps you have to convince the different stakeholders to say, oh, integration of HIV care into the benefit package does not take over your role. Your role is still relevant, your role of community mobilization, prevention mechanisms towards HIV/AIDS, being able to clearly define the roles of everyone so that nobody sees HIV integration as a challenge, to their usual activities. I think I'd like to stop here for now for time.
Yes, thanks, Frances. And when you were talking about expanding population coverage, I want to use that as a segue to for a couple of questions to Dr. Serrano. Dr. Serrano, a couple of questions for you. The first one, they're actually closely linked. How do you plan to enroll the large informal sector population in the state? Which mechanisms have yielded the best results so far? And two, how is it that the scheme is targeting, if at all, the poorest of the poor in the states? What proportion of poor Lagosians are currently enrolled, and what can be done about it? You're muted, Dr. Serrano.
As I said earlier in my presentation, about 70% of Lagos is actually the informal sector and a very small percentage in the formal sector. So now in Nigeria and Lagos in particular, you have an issue of lack of knowledge. So most people have some perceptions about insurance. So the insurance culture is actually not there in Nigeria. So in Nigeria, my colleague always says this, in Nigeria, you have to sell the insurance. People don't by default buy it. So what do we do by selling the insurance? What we try to do is try to get good soldiers in every community that we have made it such that it's their careers and their jobs that they're able to go into the communities, speak to the local carpenter, speak to the local artisan, speak to the local mason, and engage these various trade unions and groups individually to say, okay, this is what's going to happen, this is how the scheme is, these are the benefits of the scheme. And so with time, those are the people that have been coming on board. Now, we've been able to engage some stakeholders with some support at the trade union level, such that we're able to get to them and get them part of the scheme. Now, the other aspect in terms of the scheme has been $100. Someone that does not live in Nigeria, $100 for a benefit of 1 year is nothing major. But for the informal sector, that $100, the lot could be a lot for them, and that could be a lot of wages for them. So what we're trying to do is we're trying to develop strategies such that they don't have to pay at once, they are paying in installments. So if they're paying in installments, fully backed and supported by their various associations and unions, can get more vulnerable people, more people in the informal sector and their family members engaged within the Lagos State Health Scheme. So that's our strategy for getting the formal sector. Awareness, stakeholder engagement, and ensuring that the payment mechanisms are made a lot easier. Now, for the vulnerable people within the community, so I can tell you for a fact that when the law was signed in May 2015, there was actually a clause in the law that stipulated that a certain percentage of the state government's revenue must be put aside for the health insurance scheme. And this percentage is 1% of what we call the consolidated revenue fund. So 1% must be set aside. And I can tell you that Mr. Governor has actually started releasing that 1%. And as I speak to you, I have more than about 30,000 vulnerable people, that's the poorest of the poor, that are currently enjoying the scheme at the various healthcare facilities across the 20 local governments in the state. So there's actually provision for that. Now, how do we identify the poorest of the poor? So what we did was that, given the opportunity, everybody can claim to be poor to get free benefits from government. So what we did was that we went right straight into the communities, went into the slums, did a house-to-house survey to identify those that are poor, and based on our house-to-house survey, those that were legitimately poor within these slums were then brought into the scheme and government paid for their premiums. As government releases more money, definitely more and more poor and vulnerable people will be able to take advantage of the scheme. So that's with respect to the poor, and that's what we plan on doing. So of course, getting the poor on board, it's also part of the theme. Now, the other thing that we've also developed is what we call the EcoSha, that's Eco Social Health Alliance, that's SHA. This is like a fund that we've created to ensure that we get various stakeholders, high net worth individuals, philanthropic organizations that have some financing and budgets for their corporate social responsibility, such that they can actually put the fund into that EcoShare fund, such that they're able to pay for vulnerable people. They can decide, okay, I want a vulnerable people within this community, or vulnerable people within this community, or I want only pregnant women, or I want only children. So provision has actually been made within the Lagos State Health Scheme to do something like that through the EcoShare initiative. So that's how we are trying to address the informal sector and the poorest of the poor. Thank you.
Great. Thanks for those clear responses. One more question for you. What we hear often is that state health insurance schemes must mature before vertical programs are integrated at all or more fully. This suggests that vertical program services, which are often linked to the biggest burden of disease in Nigeria, are not starting priority points for insurance benefits. Can you reflect on this issue?
Okay, so now for vertical programs and mature health insurance schemes, I would say the decision is mainly a financial decision. In Nigeria, there's a paucity of data in terms of healthcare financing data to some extent, in terms of how much expenditure in granular data. So that has been the problem. So I would say that in the design of Lagos State Health Scheme, as a case in point, what was done was that, okay, yes, this is our small scheme. Let's use this small scheme, gather data from our current small scheme, and based on the data that we get from our current small scheme, we can then say, okay, this is utilization rates of people, this is how much people go to the hospital, these are the conditions that they go to the hospital for. And based on that, we'll be able to then include these vertical programs in the beginning, at the much earlier stages. Now, I would say that data has always been a major issue. If data is available with respect to costing, use, supply, demand, availability of drugs, I believe that most schemes could have actually started developing it in the beginning. Now, the other thing is also demand and supply, medications and services. So let's take case in point. If a patient has come down with malaria, the hospital providing the services already has the skilled manpower to treat malaria. The drugs for treatment of malaria are already available in the open market. This is not like HIV. This is completely not like HIV, whereby one, the drugs are not particularly available in the open market, and not all doctors are able to render such services. So that's why Lagos State is going through a phased implementation such that we're able to do that. But I believe that if a scheme or a state has the capacity that all facilities are able to offer HIV services, and if they have the data, I'm sure they can do it from the beginning of the scheme. But for Lagos State, we needed more data. I mean, let's build capacity before we can implement and integrate these vertical programs into the scheme. Thank you.
Thanks, Dr. Serrano. I'm trying to find the right way to ask this question. I'm going to pose this question to both Dr. Smile and Dr. Onwujegwe. A couple of people are asking with different wording. What should the political strategy be for implementing this type of technical projects under an administration that apparently seems to be not that committed to put money on the table? So besides the technical approaches, what should the political strategy be so that these type of projects can be effectively implemented and can be also, can have access to the necessary resources, financial resources for their implementation? Dr. Smile, maybe do you want to go first? And then Professor Robina?
Yeah, thank you, George. Can you hear me?
Yep.
Okay, great. Yeah, the political strategy, we all know that to every initiative in the country, the political economic component of that. And from our experience, given from the onset of the state health insurance scheme itself in Nigeria, some political strategies that were deployed in terms of identifying the influencers. When we talk about political economy, we are talking about those that have high interest, high influence, those that have high influence, low interest, those that have low interest, low influence, high interest. Yeah, there are always a group that has low influence and low interest. But looking at those that really have the high interest and high influence at the very, very first set of targets, you have to do some sort of a power mapping, identifying those that that have those high interest and high influence, so as those that have high influence, the low interest. For those people, all what you need to do is to put evidence together, and we have seen a lot that evidence have really done in this country. Given our experience in Kano, where actually when the law was signed for Kano State Contributory Scheme, there was no sort of earmark fund that is set for the contributory scheme. So all what it was just there are just descriptive narratives that actually no one can really lay hand on to make it as an advocacy. But putting some evidence together and those political high influence and high interest managers, and also within the political landscape as well, convincing them with the evidence that is being put forward. I think it has really, from my experience, it has really changed the landscape. And that is where a lot of people have always been saying that it's not about evidence, it's all about political. But I will beg to disagree with that kind of opinion, because we have seen right there and there where the evidence presented to the right political decision maker or influencer on the financing reforms, particularly the health insurance scheme. I think we are engaging with evidence has really turned things around and has translated to realities. And Kano State is a very good example. Despite the earmarks to the trust fund, we now also have earmark to the the state contributory scheme, which has just recently translated into budget and going to be gradually released from this quarter. Thank you, and over.
Thank you, Smile. I would like to add a little bit to what Smile just said about using the right medium to present the right evidence that would trigger response from certain political parties. And HP Plus actually had this experience in Osun State, where we had supported the state to set up all the right things that they needed to put in place for the implementation of their scheme. And the only thing remaining was the release of the equity fund for the poor and vulnerable. Osun State, of course, many people consider them as a state that doesn't have a lot of resources compared to their neighbors and other states in Nigeria. So we worked with the Nigerian Governors Forum, which is a forum that brings governors together quarterly, monthly sometimes. And we supported the National Health Insurance Scheme to develop a scorecard that actually showed how states were progressing or performing. And when this scorecard was presented at the Nigerian Governors Forum, the governor of Osun State was there, and on seeing that Osun State had met all the other criteria except the release of the equity funds, right there and then he called the executive secretary of the health insurance scheme and then told him, please send in a memo for the release of these funds. And it wasn't up to a week or two afterwards, these funds were released. So I think at this level, we need to work on what are those right mediums and what are those right messages, and who do we use to actually promote or even propagate these messages to engage these political decision makers, especially at the very high levels, to be able to get the funds that we need to implement health insurance.
Thanks, Francis, for sharing those thoughts. Professor Obina, do you have something to add on this?
No, nothing to add. Yeah, nothing to add.
Okay, sounds good. So, under HP Plus, just as a follow-up to some of the things that Francis was saying, that we have been working and providing support to LASHMA on HIV integration. We have been providing support on PFM processes and support also to the DRM strategy for NACA, for the effective implementation of the National HIV Strategy for 2021 to 2025. And for this year, we have a couple of activities that, we hope that we could be engaging with some of the people here as attendees in this workshop. On one, we're going to be assessing the feasibility, potential benefits, and risk for the local production of HIV commodities in Nigeria, which I'm sure is a polemic topic that, as I mentioned, we hope that we can engage with all of you very soon. And Francis, I was wondering if you can tell us a little bit about the work that we will be providing also with LASHMA panel facilities in this current year.
Yes, thank you very much, Jorge. So yes, so we will continue to provide support to Lagos State, supporting the empaneled facilities to actually commence provision of HIV/AIDS through the benefit package, through the LASHMA health insurance scheme. So we'll be training the healthcare providers on how to provide their services. Over the past couple of months, HP Plus has supported the empanelment of over 100 facilities, HIV facilities, to provide this care. So we'll be training them. And in addition to training them, we've developed referral and M&E frameworks, and we'll be training them on this referral and M&E frameworks to actually track the HIV services that are provided through the health insurance scheme, quantify costs, and that will be saved, to the donors that are actually supporting these processes, but also quantifying the government of Nigeria investments that are going into these services. So in addition to that, HP Plus would also be supporting Lagos State, just like from our example in Ocean State, where we supported the release engagement for the release of the equity funds. We'll also be supporting Lagos State to engage the relevant government actors for the release of the equity funds, which we think that if it's done, in certain states, people living with HIV/AIDS have actually been targeted among the poor and vulnerable. And if this is actually done in Lagos State, of course, it will increase the numbers, because I had seen a question in the chat of someone saying, oh, how do we increase the numbers? The numbers are minimal. And of course, the answer is this: because of the poor population coverage at this beginning stage, the numbers would be minimal, but we are just starting. And with population expansion mechanisms and measures, Lagos has shared some insight about how they're addressing different informal sector groups, using microfinance banks, collecting money in aliquots. The second aspect is the formal sector, where the government has actually given the approval for payroll deductions for all government workers. The next stage is to target local government workers, get them into the scheme. The next stage is to target corporate sector workers of corporate organizations, and a regulation has actually been developed for this with HP Plus support to get them into the scheme. And then all the other interventions, informal interventions that are being used to target the informal sector. So HP Plus is also supporting all these processes in Lagos State, with the hope that with this, we would be able to support Lagos State to get this expansion to 3.5 million people. And this, of course, with targeted interventions for people living with HIV/AIDS would also lead to a higher number of people than the numbers that we're showing at the moment of people living with HIV/AIDS accessing care through the scheme.
Thank you very much, Frances. So we're conscious of the time. This may be a good moment to stop. I want to switch now to Frances for some final thoughts, but not before thanking all of our presenters for their time and great work, and of course also to all the attendees. As Georgie pointed out, this webinar has been recorded. The slides and audio will be made available very soon. If you have any questions about the content shared today, please do not hesitate to reach out to us. You can see the information on how to reach out to us. You can follow us on Twitter. We have the website there, Facebook, etc., etc. So to wrap up with some final thoughts, our country director, Frances Elika, please.
Thank you very much, Jorge. And I'll try to do this in 2 minutes. So I think a lot of the presentations and exciting questions and discussions have actually shown that integration of HIV/AIDS and vertical programs into health insurance schemes is the way to go. A lot of efforts are being made in Nigeria to expand health insurance coverage, which is critical for the success of this integration process. Several mechanisms have been identified, including the technical work that needs to go in, the political engagements that need to go in, and mechanisms that could be used to engage the informal sector and actually increase the financial viability and feasibility of this integration. Now, I think another very important thing that came out is that policy needs to be developed both at the national and state level. And the National Blueprint for HIV Integration is a national policy that has been developed. Similar actions need to happen at the state level, not just developing these policies, but actually supporting the implementation, including the necessary capacity building that needs to go into that. And for states to be able to do that, they will need maximum capacity support. So this is maybe a call to all stakeholders out there to get on board to support the different states in making sure they have the right policies, that they have the right mechanisms in place and develop the roadmaps needed to implement this very important policy. Finally, Prof actually made a very vital comment about integrating health in all policies. So this is actually very important, and the time is now, especially as we're talking about building back better from COVID-19. I think this would be a golden opportunity when the health sector is in the news all the time to come up with mechanisms of actually having this health in all policies actually put in place and integrated and implemented in the country. So at this point, I would like to thank everybody. I would like to also mention that due to the need to actually explore mechanisms for expanding health insurance coverage, especially with the release of the Basic Healthcare Provision Fund, which improves financial resources available at the state level, and all the integration efforts that are going on, HP Plus would also be conducting a follow-on webinar that will be focused specifically on expansion of health insurance coverage and covering health financing gaps and universal health coverage in Nigeria. So please look out for this, and we will keep you posted. Thank you so much once again for your audience and your excellent contributions.